Hello, everyone. I'm Aimee Voth Siebert, and as my fellow panelists are being added to your pinned environment here on Zoom, we are just so pleased to join you all. A big thank you to the Vibrant team. Our panel comprises several of us who have had diverse roles within Colorado's disaster behavioral health efforts, both in preparedness programming as well as in response and recovery teams such as the Colorado Spirit Crisis Counseling Program and our healthcare worker resiliency and retention. I'm going to start our slides here in just a moment. And since people and connections are really the heart of disaster behavioral health efforts, we'll share with you today. I'd like to take a moment here to briefly introduce each of the panel members here to you at the beginning. So give me one moment to zoom our slides for you. Very briefly to just make sure I introduce folks before I get so deep into the slide deck that I accidentally skip this. I want to introduce all of you to Danielle Aguilar, who has recently come to the Colorado Department of Public Health and Environment as a public health and community outreach professional, and has served previously as a crisis counselor with the Colorado Spirit CCP. Related to the last session, during Operation Allies Welcome, she also deployed as a psychosocial and wellness program specialist, where she designed and implemented culturally driven wellness programming for Afghan refugees. Danielle is multilingual and develops and implements innovative, community-driven psychoeducational and psychosocial programming to equip diverse and historically underserved communities. And Danielle joins us today from Colorado's Western Slope in Grand Junction. Lynn Garst is the Pediatric Disaster Coordinator at the Colorado Department of Public Health and Environment, as well as the State Program Manager for the Colorado Spirit Crisis Counseling Program that just started for the Marshall Fire that happened in Boulder County. Lynn has 40 years of experience in children's mental health with organizations such as Mental Health Center of Denver and Children's Hospital Colorado, where he established and managed many school-based juvenile justice, child welfare, and outpatient programs. Lynn is an active member of several committees of the National Child Traumatic Stress Network and has a particular interest in helping prepare rural and frontier schools to address the behavioral health needs of students in the time of disaster, emergency, or crisis. And Lynn joins us today from his home in Loveland, Colorado. Juliet Madsen joins us from Castle Rock, a community south of the Denver metro. As a disabled female combat veteran, Juliet brings the perspective of a 20-year U.S. Army career serving in emergency medicine and public health to her current role as the Resilience Outreach Team Lead and Coordinator in the Healthcare Worker Resiliency and Retention Program, as well as to her previous role as a Program Coordinator in the Colorado Spirit Crisis Counseling Program, and as a person living with a disability, a former paramedic, and a graduate of the International Disaster Psychology Master's Program. Juliet has the combined professional and lived experience and knowledge to connect and collaborate with others who are impacted by access and functional needs during emergencies. And then finally, hello, I'm Aimee Voth Siebert. I'm pleased to act as moderator for this panel. And I found my way to disaster behavioral health work from an interest in community resilience following the 2005 Greensburg tornado. I was really compelled by this idea that, when 90% of your town's buildings are gone, what makes a community want to leverage a disaster and build back greener, more aging friendly? I'm coming to you today from Southeast Denver, which I call home and where I moved to attend the same disaster psychology program that Juliet did. I'm a longtime member of Colorado's Disaster Behavioral Health Program, currently serving as the Disaster Behavioral Health and Inclusion Worklead, and soon to be Program Manager of the Community Disaster Behavioral Health Program. I'm also really pleased to be connected and to serve on the Executive Leadership Committee of Colorado's Access and Functional Needs Program, and co-chaired the inaugural Getting It Right Access and Functional Needs Conference back in 2019 before all of the pandemic sort of world hit us, and to sort of see that continue in this new environment that we're in. But each of our each of us as panel members really acknowledge our identities and lived experiences of both privilege and oppression as encouragement to each of us to deepen our learning communities of colleagues and neighbors and recognize where our expertise ends and the understanding of community, the expertise in different spaces begins for others. So as our panel got together to discuss what we could share at this symposium, the objectives that you see on the screen really stood out to us. At the heart of much of the disaster behavioral health work we do in Colorado is the recognition of needs of collaborations. I think one of the panelists in the last session said that this is an intensely multidisciplinary area, and so many of our systems are both made up of people and include operations that interface with people. So we really need to be conscientious of who our programs bring to the table as collaborators, as partners, and what strategies we learn to help increase program awareness of things that affect accessibility, things that make people feel included, belonged, invested in what's being created, especially when it comes to the experiences of under-resourced and marginalized communities. We know that we learn both from the intentional programmatic design and development work, but also from things that happen in the field during response. So we'll talk a little bit about both training and resources that have either been co-developed or informed by those community voices, and what it takes to build greater accessibility and community resonance in those resources. And then here in Colorado, we do use, in particular, the CMIST, C-M-I-S-T framework created by June Kales and Alexandra Enders as an access and functional needs framework that can really help us to frame considerations, different lived experiences that communities have during disasters, and how we, as a disaster behavioral health program, connected to wider behavioral health systems, can really factor in those barriers, those needs, those strengths, and those networks of providers that really make a difference to adaptive functioning, both from the perspective of behavioral health as well as from the perspective of just disaster access and functional needs when we face the disaster du jour. So to give just a very brief grounding, I want to tell you all a little bit about Colorado's disaster behavioral health program beginnings, so you can sort of understand where some of the lessons, the stories, the highlights come from later. So Colorado's disaster behavioral health program development really started back in the very early 2000s, even late 90s, when we had the 1997 Fort Collins flood, the 1999 Columbine High School shooting, as well as then the 2002 wildfire season that affected many Colorado counties all in one go. This was also simultaneous to an era of larger emergency management coordination that was bringing more and more partners to the table. But here in Colorado, we really focused on capacity building within our local community mental health centers and specialty clinics, Servicios de la Raza, and the Asian Pacific Development Center. Thank you for that brain pause. We wanted to focus in these spaces because they are the public behavioral health system on a regular basis. And so even though we might foster specific training, specific missions and goals during disasters, having that embedded community connection has always been an important part of linking what happens in disasters back to the capacity of a community on a regular basis, because disasters don't happen in a vacuum. And we value not just mental health topic expertise, but also community-based lived experience expertise as well. the state disaster behavioral health team was formed in the early 2000s and moved over to the Colorado Department of Public Health and Environment in 2010 to really help to foster a deeper integration into our holistic health preparedness and response efforts, which were housed in this state agency for public health. And we feel that this really aligns well with the fact that a lot of disaster behavioral health missions and that principle that people are having expected, normal reactions to abnormal, disruptive disaster events really starts at a community intervention level and has very much a public health approach to the recognition that not everybody comes into a disaster with a mental health condition that will continue. We want to be inclusive and mindful of those folks that do, but many of the distress reactions that we see among our communities may be with people who don't have direct existing relationships with mental health partners to this point. And so having that sort of larger public health view of what disaster behavioral health encompasses, a resilience assumption of a majority of people who experience disasters with still the support and connections back to the wider system, the maybe more acute levels of care where needed, is really where we got started. COCERN, or the Colorado Crisis Education Response Network, was a project that was specifically designed to ask who all has a behavioral health mission in Colorado, and can we help to better understand information sharing and coordination among these partners so that we can rub shoulders effectively in disasters when they happen and have a sort of standardized training expectation, a shared understanding of what disaster behavioral health entails, how it is different from traditional treatment, how it can be connected to crisis treatment when needed. And so the organizations that you see around the outside of this slide today were folks that were involved very early on in COCERN and continue to be involved. We hold quarterly meetings to sort of maintain the relationships that foster our disaster behavioral health knowledge and programming. And we've taken lessons from very intersectional spaces, such as emergency events in school settings that have a criminal element. So unfortunately, Colorado has had its own experience with mass shootings. And in that environment, victim advocates have a critical role to play in terms of the people legally defined as victims. And then the school has a specific responsibility to the students, the staff, the people who are a part of their school system. And we know that these events have, ripples, cascades out into a wider community. And sometimes in terms of overwhelm, sometimes in terms of just reaching those wider ripples of a disaster event, community mental health centers have also brought their disaster behavioral health teams to participate in an event like that. So we intentionally build protocol documents, have these continuing meetings in order to continue to learn from each other how best to interact. And so in effect, Colorado's disaster behavioral health capacity building has gone through three main phases. The first was finding all of those collective disaster behavioral health partners who may understand that they had a disaster role to play, maybe didn't, but are part of that larger behavioral health system, and knowing how we could work collaboratively together was an important first step for us. And at the same time, we were trying to knock on the doors of our multidisciplinary emergency partners to really help them understand the value, the benefit of having intentional psychosocial behavioral health operations and missions, collaborating with them in disaster spaces, how that benefited our community members, how that benefited the functioning of our disaster systems, because there are just humans involved in so many different aspects of disaster. And I'm really pleased to say that a lot of that door knocking, a lot of that relationship building has brought us to phase 2, where it feels like there's a lot of buy-in now in Colorado around the value of disaster behavioral health work. And they say, yes, come on in, but now they're ready for sort of anything and everything. And we must be mindful of how the capacity simply of our various behavioral health partners can hit limits. And so we dream about going into sort of an emerging phase of disaster behavioral health capacity, where more workforces, more industries, more community organizations who have that trust and that more direct interface with communities see the opportunities for their own skills, their own principles, and their own practices to be guided by the recognition that behavioral health is a human experience. And when it comes to disasters, these are the things you can expect. These are good foundational level understandings of psychological first aid that can be available to you, especially when you have connections back to that larger behavioral health support. And when that happens, we see not only greater community investment, but a more tailored response to the realities of what does affect community functioning on a regular basis. And so we like to see June Kale's and Alexandra Ender's CMIST approach, this larger sort of philosophy that the hallmark of cultural sensitivity is really humility and recognizing where our knowledge ends and where we need to bring more people to the table to provide expertise in their own lives, that this becomes the mechanism by which we can continuously check ourselves and understand what is affecting our ability to adapt to the disruptions of disasters, our ability to function with the new connections, the new resources and spaces that can be brought together in the crucible of a disaster environment. So I want to sort of conclude that introductory part of our systems in Colorado and really drive this conversation now more towards my colleagues who are here for our panel to talk about the aspects that they have noticed in program design, getting ready for a program, as well as practices within the program itself that really have helped us better understand what it means to practice inclusion in our disaster behavioral health work. So Juliet, what would you reflect on from the Colorado Spirit Crisis Counseling program that you were a part of?
Hello, everyone. My name is Juliet. I was one of the program coordinators of one of the best recent examples of collaboration and design that Colorado has been a part of, the Colorado Crisis Counseling Program. The CCP is what we called it. This was a disaster mental health program that provided free anonymous care to anyone in the state of Colorado, which potentially meant we had about 7 million potential clients. We began in June of 2020 and lasted until March of 2022. The CCP assisted over 2 million Coloradans through individual and family crisis counseling, psychoeducation and group counseling, and brief contacts. The CCP team also created over 1,233,000 outreach materials in the form of handouts like flyers and informational sheets, calendars, workbooks, seasonal cards like Christmas cards, Kwanzaa cards, New Year's and Valentine's cards that we would send to community members to help keep them keep their spirits up, keep hope up. And then all the way to business cards, like something like this, which just says, I'm allowed to take up space. And then on the back, it has kind of a quick way to ground yourself. So these types of things many times were multilingual and designed for multi-generational uses. They would be in different age groups with puzzles or games for children. Elderly materials were in different fonts and different colors, so they were contrasted for elderly vision. Our teams also amassed close to 400,000 social media postings on Facebook, Instagram, Twitter, YouTube, WhatsApp, TikTok, Snapchat, etc. And then that was just the first year that we were in business, because remember that first year, most of us were locked down solid. Once Colorado opened up for in-person business, our 132 member team also supported 25,000 community members as they went out to those 400 vaccine clinics for emotional support as they were getting those shots and they were feeling really amped up. Our team members kind of helped them work through the stress of how's this shot going to impact me, or I don't like getting shots, or all that vaccine hesitancy. They were active, these team members were active at locations like coffee shops, barber shops, local restaurants and businesses, LGBTQI plus programming, skate parks. Would you think of that one? How about schools, libraries, quarantine and isolation facilities? We were even at powwows. But the key was that we worked hard to meet the community where they were, anywhere. And if they called us and said they needed us, we tried to be there. Our programs used needs assessments to identify communities that were disproportionately impacted by COVID-19. So this included older adults, children, healthcare workers, grocery and restaurant workers, immigrants, refugees, Asian American and Pacific Islander communities, the Latinx community, Black and African American communities, American Indian and Alaskan Native communities. I tried to combine those words. The access and functional needs communities in whatever needs they may have. So that's whether you think of traditional access and functional needs community or whether that's someone less traditional. So for us, that could be someone who was a pregnant mother who was high risk because they also had asthma. And so they couldn't get out of the house because they had 2 risks. So it was really important to us to think outside of the box. So with that in mind, it meant bringing American Sign Language interpreters to all of our meetings, having translation ability for over 100+ languages, ensuring that we listen to our communities before talking, and having pre and post surveys to better understand the needs of the community members when we had presentations or programs. It meant that when the turnout was low to a meeting, changing the times of the next meeting to try and improve that access. We even had one program with Best Buy, you know, the big box computer folks. They do a computer literacy program. I recommend this if you know folks who maybe older folks who aren't very computer literate, send them to Best Buy. They use a landing page for teaching folks how to use the computer. We got with them and they started using our CCP homepage as their landing page. So as they taught computer skills, they surfed all around our CCP homepage. So they taught computer skills and all about our CCP. It was a win-win for all of us. Along with these simple solutions, some of our greatest tools were, and still are, to support communities that were feeling especially isolated. So examples of organizations that we partnered with included healthcare facilities, schools, hospitals, LGBTQI programs, military and veteran facilities, homeless shelters, food pantries, and public health facilities. Families received, definitely do this, go where families receive housing vouchers. They needed extra support, so we were there where they were. We work closely with the Asian Pacific Development Center, the Mexican Consulate, and programs such as the Center for African American Health and the Denver Indian Center. So throughout the CCP, the most important practice for all of our teams was to listen to the needs of their community on a local level and adjust to those needs as necessary. Danielle, what else can you tell us about the understanding of the needs of our community?
Hi everyone, Danielle here. So we were able to listen to those needs and adjust them by using our needs assessment, which created the ability for the CCP program to build in cultural sensitivity and programming which was representative of the communities that each program worked within. So this also allowed for community mental health programs and partners to better understand the histories that the community members have experienced and to help them work through the pain and frustration of those histories confidently and in safe spaces. So how do programs build from this? And that's by networking and collaborating. So for example, through partnerships with family and cultural resource centers, relationships were built with the community in order to better understand the historical and current relationships, which in turn helps the programs better understand what resources they may already have and what they need to build or cultivate. So this also allows us to build language justice, culturally competent resource guides, basic education around the impacts of disaster, and group counseling and brief contacts, and other programming that's specific to their community. So building and maintaining these community partnerships allows us to provide psychological first aid, train the trainer, and so many other programs for both the community and the staff at these organizations, which can help fill in the gaps that were found as a result of the needs assessment, either as community education for promotion and prevention or during an active disaster. Needs assessments shouldn't be thought of as a one and done process. So even if you are informally having needs assessment conversations, these conversations should be occurring regularly to continually evaluate where you are in the process and what needs have been met and where you need to go from there. So by openly discussing the past and present and future, you can build and trust open lines of communication. We know that individuals and communities who embody multiple marginalized identities face unique barriers that significantly increase disparities in access to and quality of care. So starting with and understanding these unique barriers are what allowed for intentional and comprehensive needs assessments and partnerships. Through an equity and inclusion lens, we start with acknowledging the potential barriers like access and functional needs, the level of a survivor's acculturation, a potential lack of information due to stigma, or especially a possible language barrier, and planning for them. And how better to plan than starting with an inclusive budget? The best budgets and programs are ones which build in space for everyone. If we don't leave room to include language justice, interpretation, trainings for cultural sensitivity and awareness, then we by default will leave people out. People on our teams, people in the community, and people who have something to say that will be silenced. Budgets take time to plan out, but once they're done being accounted for, no pun intended, there's generally not a way to adjust them. So take the time to include and plan for these things, or your team will miss out on the very important cultural messages that your community may be trying to send. Messages about inclusion, about understanding, about individuals and communities who embody multiple marginalized identities, older adults, even children. So with that, that's something that Lynn is going to talk to us about.
Lynn, we're missing you because of the mute button.
My apologies. Can't keep everything together. Good afternoon. Children under 18 represent 22% of the US population. 7% of the total population is under the age of 5. Given the significant number of children in the country, the unique needs of kids must be more thoroughly integrated into disaster planning and made a clear and distinct priority. A major impediment to prioritizing children has been in their inclusion as a group within population categories labeled at risk, vulnerable, and special needs. The Department of Health and Human Services recognized children as at risk along with 10 other populations. While this is well-intentioned, the advent of these catch-all terms for diverse populations obscures our responsibility to serve each of these groups and their needs individually. Use of these generic terms has resulted in combining children, pregnant women, the elderly, and in some cases even pets into one group. This practice sends an unhelpful message regarding the unique needs of each. Even within the population defined as children, there is a wide range of specific needs. It's important to recognize that children at different age and developmental levels, children with low English proficiency, children from different cultures, children with special medical needs, and so on, have individual physical, emotional, and medical requirements. The 2010 National Commission on Children and Disasters recommended that children should be prioritized separately from at-risk populations because of their important physical, physiological, and developmental, as well as mental differences from adults and from other groups. Most of the recommendations of this report have yet to be implemented. However, I am really pleased to say that just this week, this particular recommendation was finally enacted through the Homeland Security Act for Children. This requires that the Department of Homeland Security ensures the needs of children are considered in Homeland Security planning. Among other things, it creates the position of children's technical expert within FEMA to coordinate this integration. Next slide. During disasters, children interact with and depend upon multiple systems and organizations. Effective emergency preparedness and response activities need to be coordinated across these systems. Here are just a few. We recognize that this is certainly not an exhaustive list, and it will vary depending upon each state and each locality. I want to highlight 3 Colorado cross-discipline collaborations supporting our children. Oh, you're muted.
My turn. I advanced multiple slides and I got thrown off, but I'm really excited, Lynn, for you to talk about how, having recognized these coalitions of service providers, the various people who at different points in time are caregivers for children, and having brought them to the table, how that has shifted both the development and the distribution of particular trainings and resources to this particular group. And I think this highlights for us both really cool work that's happening in the realm of children and youth in disasters, but also highlights some of the inclusive practices across the board that we've been trying to implement in different disaster behavioral health teams. So what would you share about some of the trainings that you've been putting together in your time with the team?
You know, I want to first talk about schools, because schools and school staff are often the first and last responders for kids. They're there during or shortly after a disaster or emergency, and they're there long after other services are gone. Schools provide safety and predictability for children and allow them to develop social and emotional skills and build positive relationships with peers and adults. For many communities, schools are at the center of promoting community cohesion, particularly in rural areas. While schools are often included in emergency planning, we have found that very little attention is given to preparing teachers and staff to support students when something bad happens. In order to better resource teachers and school staff with skills and strategies for supporting their students during and after a disaster or emergency, we developed a training in psychological first aid specifically for them. It's based upon the 5 core principles identified by Hobfall and others in the seminal 2007 research. Based upon the 5 core principles, we have tried to help teachers really identify that these are the same skills that they use every day to support student learning. Promoting safety, comfort and calming, social connectedness, self-efficacy, which we define as success, and hope, or a sense of future. So the training is provided free of charge, and we've held several training of trainer events in Colorado in conjunction with the Center for the Study and Prevention of Violence at the University of Colorado. This is to help promote further dissemination of the information. And we also work closely with the Colorado School Safety Resource Center, as well as local school districts in providing this training. It's also been adapted for preschool programs, and we provided a training for the entire early childhood division staff within the Colorado Department of Human Services. Over the past couple of years, we've been working with the School Safety Resource Center, the Colorado Department of Education, the Colorado Society of School Psychologists, and several large school districts to develop a statewide school crisis response plan. This plan covers guidance for developing a statewide system of crisis response teams, as well as for local school districts in preparing for the emotional impact of disasters and school emergencies. This training has been included as a suggested training for local schools. We also recognize that there are few resources to help support early childhood and childcare programs in preparing for disasters. We've worked closely with School Safety Resource Center again in providing training to both preschools and in particular family and in-home providers to develop their own emergency response plans. The School Safety Resource Center provides training primarily for school-based preschool programs and some of the larger programs. So we've really focused on supporting the small family or in-home programs, which actually represent the majority of early childhood providers in Colorado. Many of these providers are located in underserved areas and provide a significant amount of preschool population. While we really focused on the development of the emergency plan itself, we also provided additional information and resources around providing that emotional support if something bad should happen. We also work closely with healthcare, in particular emergency medical services and emergency departments in improving their care for children. In that work, we found that many responders become really anxious when dealing with children. We recognize that some of that anxiety is associated with providing medical care. But we also found that it came from not knowing how to deal with children, especially when they're in emotional distress. As a result, we pulled together a group of children's mental health professionals, paramedics, child life specialists to develop a resource kit providing strategies and activities for providing and promoting emotional safety, quickly engaging and building rapport with children, and providing calming and distraction activities. We recognize that by improving responder confidence and competence in working with kids, we also had the benefit that children tend to do better. You know, the earlier we can intervene when kids are in distress, the better not only the mental health outcomes, but the physical health outcomes as well. So the kit provides common distress reactions, and this is all broken down by developmental level. And then we provide developmentally appropriate calming and distraction activities. So the focus really is, again, on skill development of providing strategies and activities really designed to help reduce children's distress. As we promoted this, we began to find that non-health providers were kind of excited about what information it provided. So we, over the last year, have adopted that and adapted it for non-medical providers such as teachers, disaster behavioral health responders, and individuals in community-based organizations. I remember when we first published the book or the kit, I was showing it around the office, and one of the new dads grabbed it and said, "Boy, I can really use this." So we've also found that this resource is valuable for a just-in-time training following a disaster or emergency, particularly in a couple of instances where schools were impacted by disasters, in one case by a shooting. Providing that information right before the kids came back at the beginning of the school year. We typically try to develop and adapt resources during the preparedness phase of disaster planning. But we also recognize that there are times when we don't have resources available that we might need during a disaster. And so there have been times when we've done adaptations and even developed new resources in response to a particular event. For example, we recently worked with translators to have this resource made available in Ukrainian to assist in the response to the war and the following refugee crisis. Actually, this resource is available online. The link is at the bottom of the slide, and I also will include it in the chat.
Thank you, Lynn. This is Aimee chiming in again. Your reflection, even on the insight that led us to develop some of the adaptations of this resource, really resonate not just in this area with children, but the recognition that, as you said, sometimes we plan for these adaptations, and then sometimes we hear in the middle of disasters that somebody else would be interested in some of the resources that we have to provide. I'm sure that's familiar to others who are here on the symposium with us, but it makes me think of when we discovered partway through the pandemic that especially the case investigators and contact tracers of our pandemic teams were interfacing with a lot of people the first time they realized that they had COVID, and the distress that came up with that, or came up with having to share who they were interacting with, meant that psychological first aid as a training became something of great interest to those team members as well, and thinking about how they could anticipate stress, and even in those phone-based conversations, provide a little of the same care that PFA provides. I also reflect that it has been really powerful to integrate some of the Engage, Calm, Distract content into our standard psychological first aid training. We had a Train the Trainer event, which we also see as a good program practice for ensuring that more training capacity exists across different multidisciplinary partners, has a greater reach geographically in a very sometimes separated and isolated state like Colorado. And it was great to be able to provide this content as a part of that Train the Trainer practice as well. Danielle, I wanted to come back to you for one of our sort of final sessions, or our final sections of this presentation, and also invite those who are attending to drop any questions into the Q&A portion that you would like our panel to take a look at here at the end. But Danielle, as mentioned before, you had a chance to deploy as part of Operation Allies Welcome, and I wonder what you might reflect on seeing as inclusive lessons, inclusive practices that were underway in that very innovative response.
Yeah, absolutely. Thank you, Aimee. The entire deployment consisted of everyday innovation, which I did hear that echoed with the previous group of presenters. We tailored psychological first aid training to different groups of responders and guests that were based on so many factors. Responders ranged from a first time ever deployed AmeriCorps volunteer to a veteran interpreter with the International Rescue Committee. Being that Operations Allies Welcome was a historical effort, even the veteran and international disaster responders had never seen anything like what they were responding to before. So a lot of interpreters, for example, were also from Afghanistan, of the same culture, religion, and background. And so that impacted them mentally, emotionally in ways that even they couldn't anticipate. So we immediately saw the need for a sort of psychological first aid onboarding with either new or rotating interpreters, the new AmeriCorps volunteers, or other supporting staff that was based on their experience in disaster settings and especially personal connections to the survivors and guests, whether they had any formal or informal psychological first aid training altogether was important as well. So now, apart from the responders and support staff, it was critical that I took the time to sit in with the guests to listen to specific needs and challenges that they were immediately facing, as well as what their beliefs and values were in regard to topics like self-compassion or self-care, so that I could tailor psychosocial wellness programming for them that included the cultural and religious sensitivity that was not conflicting, but rather parallel to their unique needs. And talking about access and functional needs, there were large amounts of guests with physical injuries and without education in writing or reading. So verbal communication was then going to be the most effective. And sometimes as a buddy system with a relative or a new friend was what worked as well. So that's aside from factoring in the multiple dialects spoken and taking into account the subtle or even drastic differences, not just linguistically, of course, but also culturally. Educating our interpreters in basic disaster education helped to normalize and validate what they were experiencing, being that they were so critical to our response efforts. Vicarious trauma was going to impact every person responding. So taking the time to sit and listen and then ask questions in order to best understand where everyone was uniquely at, made for an inclusive and accessible programming, which is what we did with the CCP in Colorado. And having stepped straight out of the CCP and going to respond to Operation Allies Welcome just had a prime transition for me to go over and apply everything that we did in Colorado with the CCP to the response effort. One of the most important everyday innovations was actually starting our day with intentional self-care plans and accountability. We're most likely to follow through with self-care and when starting our day with intention. So we incorporated a quick huddle with all responders as we started in the morning. This included all of our interpreters that were going to be with us that day. And we did a quick huddle at the end of the night. So that was something that ended up being completely invaluable, but something that we also taught to everyone that was involved in the CCP in the state of Colorado. So thanks for bringing that up, Aimee.
Thank you, Danielle. I love that we sort of brought this back around again to this, idea that disasters are disruptions for everyone, and that even the act of being involved in a response brings up new stress. And so this public health approach to disaster behavioral health that recognizes this is a need, a consideration, something that should be centered for all people involved during a disaster is really powerful. So thank you for bringing us back around to self-care and really thinking about all of the different kinds of people who make up our response teams, especially when it comes to those functional services like interpretation and translation. So what is one or two things that you would like other programs and organizations to take away from the lessons you've learned in designing programs and trainings? I'd love to just go through the panel and have each of you all name those things. Danielle, would you like to start?
Yeah, absolutely. I would say that the greatest takeaway from 2 years in a federal disaster declaration response team was that there are so many things that we do know and understand, and starting with what you do know and understand and putting that on the table, but leaving an equal amount of space for those that we still do not know and open to that fluidity. And there is nothing more fluid than the pandemic in itself. We had changes daily, weekly, monthly, things that we thought we could rely on to expect that didn't come into fruition, or everything was just so fluid. And staying and maintaining in that state to yes, these are what we do know and this is what has worked, but equal amount of space for so much more that we are still yet to learn and staying fluid with it.
Juliet, what are you reflecting on?
I agree, flexibility was absolutely key. So thank you, Danielle, for bringing that up. I think another one that we really hammered in on and everyone was completely uncomfortable with in the beginning and by the end was a mantra, was self-care. No one likes the word self-care. No one. I don't like the word self-care. But if you build self-care into your world, and self-care means something different to everyone. I am not going for a mani-pedi. That's not me at all. But I will happily sit with my grandkids and watch a movie or just tickle them or whatever. And I consider that self-care. So if you build in an extra 10 minutes of whatever you consider self-care into your world and are very thoughtful about that, and we developed conversations around that, and we discussed it at all of our team meetings, and we built that into our reporting system. So we had our team managers had to discuss it with each of their team members, and they had to write about it in their reports. And so each week it really was its own thing. It wasn't something that people could just mention once in the beginning of the program and then hide. We really had to discuss it. By the end of the program, our teams were very strong because of it. I think Danielle's team is a beautiful example of that. When they went away, that self-care became a coping mechanism that they were able to lean on. And so I know people don't like that expression of self-care, like naming it, but I really think that teams need to make time for it in the design of your program, in the planning.
Lynn, how about you?
Build relationships. It's really about identifying those groups, organizations, agencies that really do support whatever population you're looking at during disaster. The vast majority of my time, I've been with the Department of Public Health for 7 years, has really been about identifying and working with groups within the communities. And it's really out of that we began to identify, what are the needs? What are the ways that we, as the state disaster behavioral health program, can support you when you actually have to provide the response. And the interesting thing about building a relationship with one organization, suddenly it's, well, are you familiar with? And that really expands that network. We always talk about how critical it is to build those relationships before something bad happens, because you're not going to have time during a disaster.
Thanks, Lynn. I think I would reflect that for a long time, emergency management, disaster preparedness work has often been based on the hazard itself, right? We're getting ready for a fire, we're getting ready for a hurricane, we're getting ready for a public health emergency, whatever it is. And to recenter what it is that people experience, both in the event itself, but even before the event, because disasters don't happen in a vacuum. And so infrequently do we bring community conditions and I'm talking about community people, not like infrastructure, not like, you know, which disasters are likely to show up, but so infrequently do we bring disaster or community conditions in as our situations and assumptions in disaster planning that we know, you know, we already had a housing market just that was very, very unfriendly to anybody who didn't have like a 6-figure income. And then we're hit with a flood that wipes out basically the housing stock of 13 counties all in one go. Or we're in the middle of, you know, price hikes that happen and we haven't recognized that there are communities who are already in particular apartments having, you know, 5 people living in a room at a time. And so like those types of conditions, especially when the disaster disruptions are likely to intensify or rely upon the community's ability to do certain things, those ought to be part of our focus because they are absolutely part of the stress and the disaster that is caused. And simultaneously, like it's not just about needs and difficulties that people face, it's about the strengths and the connections that people have on a regular basis. Like how are we building those into our assumptions? Because disasters feel less like a disaster when we can continue to do the things that are familiar, that are comforting, that connect us to the things that work for us on a regular basis. So how are we've done a lot of work for a long time in emergencies to think about continuity of operations, but how are we thinking about continuity of community and using what works well on a regular basis and recognizing simultaneously where disasters can be that crucible, flexible, as both Danielle and Juliet said, environment where we learn how to do something better. And it becomes more equitable as a process of saying that now that the rules or the structures are out the door, how can we make this work for a better new normal afterwards? I recognize we only have 1 minute left, but I did want to acknowledge the other question that came in, which was any comments on disaster response experiences of disaster relief workers after school shootings? And Lynn, if I can throw that to you, it makes me think about sort of what we learned about training following the school shooting that happened here at the STEM high school.
Yeah, you know, we have to recognize again that teachers are responders after that kind of event. So really helping resource them. You know, with this particular incident, we had planned to do some training around psychological first aid and actually do the supporting students during crisis. And after that first training, I realized that they didn't need training in psychological first aid. They needed psychological first aid. So we totally adjusted the training, went back and provided the engage, calm, distract, which seemed to be kind of a relief. I mean, they already were doing these things, but when your brain shuts down, you kind of forget that you're doing them. So really providing that support and then providing a lot of emotional support to all of the providers. Our community mental health centers have taken the lead in most of the school shootings that we've had in Colorado in providing that support. So, you know, one of the things that we do at the state level is really to try to help ensure that the local community's mental health center or the COVA, our victims assistance, are getting kind of the support they need to continue providing the support to the survivors.
Thanks so much, Lynn. I would reflect too that in recognizing that we have sort of these dual identities as both responders and survivors, especially of events that are close to the community we feel part of, there are sort of critical periods in which additional support is really powerful too. And I think we've learned across some of these events in Colorado that the reentry moments are really important. We have definitely taken lessons from the crisis counseling program about the criticality of anniversary events. And when these events even happen in other communities, just recognizing that there are echoes and ripples that we want to be mindful of in the communities that aren't experiencing it now, but are remembering what has happened for them in the past.